I'm happy to welcome you as I had the honor to serve as the Congress President this year. So I think EHA meeting is really beyond the geographical borders of Europe. We really have here participants more than 15,000 from all over the world. And that tells you a little bit about the role of science, because we have to work together, and together we achieve more than we achieve on our own. So this is exactly the role of this annual meeting. We present our news data, and also we networking to plan the next steps. So what are the highlights here at EHA 2025? Well, really a broad spectrum of different news, and a lot of them, in fact, practice changing. So when you come back from this Congress on Monday morning, taking care of the patients, there are some distinct changes. And let me just mention a few of them. Well, first of all, it's a little bit reassuring that these news come from all over the world. US news were also in the recent years, but especially I would like to refer to Asian news. And China had been presented in the plenary session, in the late breakers as well, and in the disease-specific highlights. And so this is really very well taken that we get these high quality data. And just to give you a little bit of sense what we're heading to. Let's start first of all with multiple myeloma, both in the plenary and in the late breakers. The new thing is immunotherapy. Well, you might say, well, CAR T cells are already standard of care in relapsed multiple myeloma. Yes, that's true. But multiple myeloma is really the high-speed train of clinical research. Just about 2 days ago, our EHA guidelines have been published on multiple myeloma, so I refer to the full publication. But what is fair to say, on top of these well-established standards of care, there's a little bit of revival of belantamab, now not as a monotherapy, but in combination with other targeted treatments. So this is good to have a plan B in patients where, for whatever reason, you're not able to apply immunotherapy. On the other hand, moving on from the CAR T cells we have so far, and these are mostly BCMA targeted, it's fair to say we try to increase efficacy and avoid resistance. And therefore, combined approaches is the answer. And again, both at the late breakers and at the plenary session, two different approaches had been presented: a tri-specific CAR T cell construct targeting two different epitopes, and response rate is 100%. Well, you can hardly improve on that one. Quite striking. Tolerability is feasible. So I do think these combined approaches will take over for the future. Now, this tri-specific CAR T cell is not yet available, but what is available are bispecifics targeting the different epitopes, and a combination study had been presented at the late breakers, and there we could really see striking response rates, almost as good as the CAR T cells, not just, but really convincing high CR rates. And the question was brought up, now when we're getting back to our home institution, treating our next patient with relapsed mantle cell lymphoma, is it already prime time for these approaches? And the answer was a clear yes. If this is available to you, this is the way to go. And now moving on, for example, there had been striking use on AML with menin inhibitors. These are, not the new kids, but meanwhile the established kids in town, and they will revolutionize treatment in acute myeloid leukemia. So my thought, to be honest, 10 years ago was we definitely need high-dose chemotherapy to overcome this disease. Now we have these high-efficient targeted approaches, and we're moving from these toxic, yes, efficient, but also toxic high-dose therapy to these targeted approaches, and that will really change also our dogma of inward treatment of AML. And finally, just to allude to another point, what's new in the lymphoma, and it's fair to say also in the lymphoma, immunotherapy is a strong subject. So at this meeting, again, first-line data have been presented, applying bispecifics either in combination with a standard R-CHOP or skipping R-CHOP and just applying a toxin-labeled antibody. And outcomes are extremely good in phase 2 studies, and we're eagerly awaiting to confirm these data in phase 3 studies. However, there's one phase 3 study being presented at our plenary for the first time ever, which definitely does change standard of care in diffuse large B-cell lymphoma, and that is comparing the formal standard R-GemOx with an experimental arm combination with polatuzumab. Now, polatuzumab, again a toxin-labeled antibody, had been registered based on a small phase 2 study comparing it to BR bendamustine rituximab only. Now, this is a well-established regimen in indolent, but not in aggressive lymphoma. And in fact, it does have some disadvantages that we hamper subsequent treatment with immunotherapy. So therefore, this study is so important. And what have we seen? By addition of polatuzumab, you increase specifically the CR rate by 20%. You do increase PFS significantly in about 15 to 20%, and you also significantly improving overall survival, achieving long-term remissions. So therefore, my take-home message is next patient to be treated with relapsed DLBCL, either bridging to CAR T cells or maybe later relapses where we can't apply CAR T cells. This is the way to go. Thank you for listening to me, and my best wishes here from EHA 2025 in Milano.